President, start.
Rahul?
Yes.
We are live. London is live.
Everyone is live. We can start.
All is live. Nice, good. 112 is people there, so we can start now. Now time is 6:05. Kavinder आ गया क्या?
Let me see.
Yes, Kavinder.
Kavinder is here. Yes.
Kavinder is here. All right.
Kavinder, I made you the co-host. Now you can unmute yourself.
Now that's why. Dr. Rahul is there.
Yeah. Rajesh का कुछ बोलना चाह रहा है? I think.
Yeah. Rahul sir, I can hear you.
Yeah.
Yes, Rajesh Bhaiya. I have
Rajesh बोलना चाह रहा है? I think.
Yeah. Rahul sir, I can hear you.
Yes, Rajesh Bhaiya, I have unmuted you.
Yeah. Rahul sir, I can hear you.
नहीं हो रहा, I think there's some connection issue. We should start, please.
Bit like that.
Hello.
Vishnu, go ahead. Vishnu, we lost you. Go ahead.
There was some internet connection issues. It is resolved now. IT, can I start?
Yes, please start.
Welcome everyone, dear members, dear viewers and of India and abroad. Namaste and welcome to each of you. At the outset, I pray to the Almighty that normal life comes to existence at earliest for the sake of humanity. We VIP are the oldest association of Eastern India and I love it, I enjoy it. I just start my speech with a Sanskrit sloka. Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pasyantu, ma kasyit dukh bhag bhavet. I extend my heartiest thanks to Dr. Rajesh, my good friend, and Dr. Rahul, to be friend, who are from Indian origin and now practicing in UK. Dr. Rajesh is practicing in preventive medicine and Dr. Rahul is practicing in respiratory and ITU in NHS. Produced to all of you for the benefit of all and each of our near and dears. For the grand success of this event, we are thankful to our 14 supporting organizations from Eastern India and other part of India. Facebook group of UK is also live. I now read out each one of them here. Just a second. I got the support from ACAE, Avantika, Bangu Revenue Sangh, Central Calcutta Sea Association, Howrah Chamber of Commerce Industries, Lions Club Park Street, Lions Club Toliganj, MMI South City, Kolkata, Purva Kolkata's Nagrik Parisar, Rotary Club of BSSR, Tosili, Odisha, Rotary Club of Central Kolkata, Sri Jain Svetambar Terapanth Sangh, Turf from Bihar section, Milab Batika and Vitt Salakar. Apart from them, many organizations was willing to join indirectly and supporting to us from the back of the side. Friends, Now, without wasting time, now I hand over the proceedings to C.S. Subodh Agrawal ji, our founder member as well as our past president of ICI. Thank you everyone for joining this program. Now over to Subodh Bhaiya.
Thank you, Vishnu, for organizing such a fantastic program, which was the call of the day. Good evening, friends, to all of you in today's awareness program on topic, here is the answer to COVID. Friends, this program is being addressed by the world-renowned doctors, Dr. Rajesh Hemrom and Dr. Rahul Sarkar. Both are from the Indian origin and well-known. Program has been organized where there are, as President Vishnu also informed, more than 17-18 organizations. That is, the entire society is involved in organization of this program, and Vishnu is only the flag bearer. Friends, I would like to say happy COVID. You all will be wondering why happy COVID. As I feel that we need to learn to live with COVID. And that is the reason the topic today is care is the answer to COVID, like we care to our relatives, our friends, everybody. Friends, the first phase of COVID was horrific, terrible, as nobody knew what it is, from where it has come, whom it is going to impact and affect. It impacted more to the Western countries where both the doctors are sitting today. But then we thought that we are immune, we are very hardworking, and it will not be impacting. Our immune system is very strong. It will impact only those living in AC, air conditioned, and high-rise building. But now it has proved to be wrong. However, by first phase, we became aware and come to know about mask. What is mask? Previously, only our Jain Munis used to use the Japanese used to wear the mask. Sanitizer. I never used sanitizer before this COVID. We started avoiding crowd, which is hallmark of India, and we started to take vitamin intake. Even though we take milk, green vegetable, and then warm water, etc., etc. Again, when second phase came, we thought we are Indians. Nothing is going to impact us. But then it came as a tsunami, COVID tsunami. And that is the reason that till 15th April also, we were moving around like unaware. But when we started pouring in the shortage of the oxygen, हवा की भी कमी हो सकती है, हमने कभी नहीं सोचा था. हमारे घर में, हमारे बगीचे में, हर जगह पेड़ ही पेड़ है. But then suddenly we found that people are dying because of the oxygen. Though we had sufficient stock, production capacity of oxygen, we are the producer of medicine for the globe. But then medicine is scarcity. Hospital beds, we suddenly found that the hospital beds are not sufficient. Probably everything is there. It was not organized. Today, when we started, the industrialists came forward. Even at the cost of their production, now we are finding that no, oxygen is not in scarcity. Medicine, the moment the apex court said, just emulate Bombay way of managing the COVID. Now everybody is looking how Bombay managed it, even though that is on the peak of the entire world. Now today we find that it is a decreasing trend. In India, today we are producing 50% of the total COVID patient on a daily basis. But if you look at recovery, it is also fantastic. We woke up late, but then it is never late. Today, we find that the things are quite under control. Friends, what we need to do, take care, and care. And that is the reason that there are two doctors, Rajesh and Rahul. Now, without taking much of the time, thanks a lot. There are more than 160 people, those who have already joined, over to the organizer, Vishnu, and to the concerned person. Thank you very much. Vishnu, your voice is not coming.
Over to Rajesh Bhaiya. Rajesh, welcome.
Can you hear me?
Yes.
Yeah, okay. Good afternoon, everyone in UK, and good evening in India. So, Firstly, thank you very much, Vishnu, for organizing this. As all of us are aware, what challenges we are facing back in India and what the situation is. I don't need to say much because I think there is enough and more media coverage about it. But we thought when you asked me to come and give a talk, it reminded me of a year ago when we did a very similar program and we had an event looking forward. And we were quite skeptic at that time that, although we think that India was not having that much problem at that time and UK was having a lot of problem, I think the coin has flipped. And now we are in a situation where, at least in UK, we feel that we have gained a reasonable amount of control on what is happening around. And our second wave is almost over for us. But unfortunately, back in India, it's a very different story. So I've got a very esteemed colleague and friend of mine who will be joining us, Dr. Rahul Sarkar. He belongs to Calcutta. He is from there. He has studied there and he's doing a fantastic work in UK. And I'm very privileged to work along with him. He has looked after thousands of COVID patients, and he has got a very unique qualification. He's an intensivist, as in he works in ITU, but he's also trained in respiratory medicine. So he looks after lung diseases as well. So this is a great combination where, because COVID is primarily affecting the lungs and many of people get very unwell and they need to go into high dependency unit or ITU. So I'll be really looking forward to listening to him. So starting for what I came in to just share a few things. I'm trying, when I started preparing, I was wondering, how should I pitch as a doctor or as a person who belongs to India and also has learned from there and something to give back to you. Now, one of the big problems we have had in the past 1 year is that we let our guards down. And it's not just there, it's everywhere, not just in India. We have had this problem in UK. We have had this problem in Europe, America, you name it, and every country has gone through this. Yes, the kind of guard we let down may have been different, but I think it's time that we get things right. It's time that we do things in the way nature intended us to do. So I'm going to focus on primarily things which I told last time. जो पिछले साल हमने कहा था, almost same मैं repeat करूँगा, और उसके साथ जो नई बातें अभी आई हैं लाइट में, उस पे थोड़ा सा टच करूँगा. तो let's walk through the presentations. Now, before that, there's a request that those who are attending through Zoom or through Facebook, please type in your questions and we'll try and answer. We have kept a lot of time at the end to answer those queries. We're not taking verbal questions because there are so many participants, but please put in your questions and people are going to help us assimilate those questions and we'll try and give the answer. Also, we want to make some declarations. This is not something we are intending to provide medical advice on particular cases, but this is for general awareness. And also this is primarily meant for those who, don't work in medical field. So if someone has very specific questions, they can always ask us through Vishnu or directly, and we'll try and answer after the meeting. My main aim is to share our story and experience through the COVID pandemic. We don't want to make judgment about how things are being handled in India, because you are the best judge. You are sitting there, you're watching your news, you know what went wrong. We have to just put our hands on our heart and say, yes, we didn't do this well. We could have done this better. And let's do it correctly now so that it doesn't happen the same way in the near future. Because whatever said and done, unless there is a definitive control on the pandemic, we are very likely to see waves after waves. So this is not the end of it. So let's prepare for future as well. All these views are my own, and I would talk for Rahul as well, that these are our own views, and we don't have any conflict of interest to declare. We don't hold shares in company, or at least I don't. Rahul can tell for himself. And we haven't been paid by anyone to make this presentation. So coming to our basic principles as doctors, as medical professionals, first thing we learn in our medical school is do no harm. So when we try and treat someone, when we try and look after someone, the first thing we have to remember is we shouldn't do anything which will actually cause harm. And that is something we are observing, which may be happening, where we may be trying to help and intentionally or unintentionally, we may be causing some harm by treating or over-treating. So we'll touch a little bit on that. And the other thing I wanted to say is that, as they say, with great power comes great responsibility. And this can't be more true than ever, because we have got the biggest pandemic in the current era, in the last several hundred years. We have got people with great powers. That includes politicians, that include policymakers, that includes executives who actually have to make things happen. That includes the doctors, the nurses, the medical community. But more importantly, that includes you, because you have the power to help yourself in this very dire situation. So you have all the responsibility on your shoulders. And if everyone takes those responsibilities, we can have a much, much better control over this pandemic. Okay, so I'm going to start with my story, or rather our story. As you can see, already my junior Dr. Hemram is sitting next to me, as he calls himself. So that's my wife, and Daksh, or Jonathan, my son. And Kashmiri is a medical doctor. She's a consultant who was extremely busy during the COVID time because she looks after COVID patients. So why have I brought this up?
No.
So we are talking about my family because in April last year, when we hardly knew about COVID, we were just in the initial phase of COVID, both of us got COVID. And that was the time when we had lots of our Black and minority ethnic colleagues, so Indians and Pakistanis, Bangladeshis, mainly I'm talking about the doctors and the nurses who are working with COVID patients. We were getting unwell, and unfortunately, we lost a few colleagues. And actually, that number kept increasing. So when we both had COVID infection, first Kashmiri got it. I suspect she got it from her workplace, and then I got it, and we both were tested positive. Daksh, at that time, he was too young to be tested, so he didn't have a test, but we are 100% that he also got COVID at that time. So what did we do? We, both doctors, we have access to everything. We have access to investigations. We have access to treatment. Of course, we have a system here to follow. We can't prescribe ourselves, but we have colleagues who would have treated us. But such was our knowledge at that time that all we had to do is sit at home, monitor ourselves. And at that time, we were not doing oximetry or, watching our oxygen saturation. But just mainly monitoring our symptoms, like are we becoming breathless? Are we, we had fever, we had diarrhea. I was feeling like 2 trucks have gone over me. I was feeling like the worst. I was feeling the worst in my life at that time. So I was counting my days because we knew the second week is very crucial. At the same time, Kashmiri was looking after patients in the wards. So 1 week, and she started feeling better. So she went back to work, but I was at home with Daksh. So why I'm telling this story is that we didn't run around at that time, even though there were things like azithromycin and hydroxychloroquine, which was, quite in fashion at that time. We had some other drugs which were experimental. We didn't need it because at that time and throughout the pandemic in UK, nearly 95% of the people were just sitting in their houses, isolating. They were keeping others safe by not going out and were monitoring themselves in their homes. And I suspect that is exactly what, even now, despite the mutant varieties of the virus, and despite not having a very structured healthcare system in India, we still can achieve if we follow some very basic infection prevention methods. So right. So as I was talking about, that was our story. This is about our friends and other families who were in UK, and also friends and families back home. Now, many of them got infected. Majority had mild illness. They were all requested to isolate themselves for 14 days, and the contacts were quarantined. So people who were in touch with that particular patient or particular person who had COVID, they also had to isolate. There was no high-tech monitoring for majority of the people. There was there was some oxygen saturation monitoring, and this was happening in some care homes, in residential home where older people were there. But majority of the public were just at home watching symptoms. If they became breathless or they had very severe symptoms, then they called for medical help and they were taken into the hospitals. What we did in hospitals was that there was very strict triaging. And by triaging, we mean that people who were seeking help had to meet certain criteria before the hospital would admit them, before they can be given oxygen, before they can be given, medication like steroids and other medication. And the beds were reserved for only appropriate cases. So it did not mean that whoever turned up was going to be put in a hospital bed. We had to do this because triaging is very important in the front door of a hospital. If you do not triage, even in a normal time, you may have people who would overwhelm the system. So the biggest problem with COVID is that if it happens in a very short period of time and many people have it all at the same time, the health system just crumbles because nowhere in the world has anyone prepared for those many patients to be admitted and looked after at the same time. So that is what we had to do in UK and many other countries, especially in Europe. Now, all these patients, and the vast majority of them, stayed just with mild to moderate amount of symptoms. They were looked after in the community. And unfortunately, of course, those who were very old, those who were in the high-risk group, they became unwell. And for them, either they died, or if they could be salvaged in the hospital, they managed to get through the illness. So what treatments did we use and throughout the period, and Rahul is going to shed some more light on it, but this is all we have been sort of working on. And it's not that we don't have facilities to have drugs which are, costlier. So, we have easy access to remdesivir, tocilizumab, you name it, and most of the drugs we can access. We have strict guidelines around it. So we need to know when we can use it. Rahul uses it all the time if necessary, and not use it when not necessary. So he's going to talk about it. So oxygen indeed is required for patients who have respiratory problems and which is not getting better and only getting worse. So we did have some situations where we were running short of oxygen in a few hospitals, but luckily, because there's a full link of hospitals, so NHS, which is National Health Service, is a big organization which essentially is all across UK and links up every hospital. And there is this almost like a single policy for everyone, whether it's the right policy or not, but at least there is a unified policy. So we can help each other and we can share the resources. Steroid, definitely useful, but in the right context. And Dr. Sarkar, Rahul Sarkar, was quite involved in the trials, which actually proved in UK that this is one of the most useful drug. He will talk about it. Then all of you have been hearing about blood thinners. With my hat from the preventative medicine point of view, vaccines are the key. Vaccine is what has saved United Kingdom and its people at the moment, because undoubtedly we have had one of the best mass vaccination program globally. Now, in our second wave, luckily, most of the vulnerable people were almost vaccinated with 2 doses, if not at least 1 dose. And what that has done is that even when there was second wave, we managed to scrape through it fairly safely and without much harm. So, vaccines to me is the key. And I think what India needs, or what we think India needs, is a vaccine program which is unprecedented. We have 1.4 billion people. Vaccinating the right group and all the people is going to be a massive task, but that's where should be the focus of the authorities. Now, what did we not use? We didn't use doxycycline, we didn't use azithromycin, we didn't use ivermectin, hydrochloroquine, etc. They were used mainly in the research setting, and those research have also stopped, those were stopped long time ago, even in research setting. Other medications which you hear a lot, which is being sold for, thousands of Indian rupees, sometimes even over 1 lakh, things like remdesivir, tocilizumab, they are very infrequently or rarely used, and Rahul will touch on that. And they're used in a very specific group of patient. We pretty much don't use any plasma therapy in UK. Very, very rare. Okay, so what is my message? My message is that we in the West, unfortunately, were victim of the first and the second wave. We had this before it happened in India, and we have learned from our mistakes. We would like to share it with our people. Both Rahul and I have grown up in India. He in Bengal, I grew up in Bihar. We have studied there. It's not that we are outsiders. So it is in our best interest to make sure that mistakes are not made in India the same we made, only a few months ago. So what is the UK story? UK story is that initially when COVID reached in March, April last year, experts warned about it, but the government was in denial initially. Quite quickly, it all became very obvious. WHO told everyone, this is not just a simple virus. Pandemic is on its way. We then had quite a bit of delay in locking down, and that led to quite a lot of rising infections. And then that did not spare anyone. And as you may have all heard, our Prime Minister Boris Johnson and the Health Minister Matt Hancock, they both got COVID. So it just shows COVID is not going to spare anyone, whether you are, a high-flying minister or someone on the street. We did have then some policies which led to some control. We then had full lockdown in the summer months, going all the way towards September. Schools were closed, and the situation improved. So what happens when situation improves? We get a bit complacent. We become a bit overconfident. We become careless. And that happened in UK as well. We saw scenes of people going on the beaches, thousands of them in train stations and pubs, bars, and even government, to help people with their livelihood, opened up restaurants and pubs. This was around the September time. And very soon, again, all hell broke loose. We had a second wave in Europe, and that led to us making a second mini lockdown in UK. Luckily, the vaccines became available in about November time, December time, and December, it got authorized for emergency use. We started vaccinating people. However, hindsight shows that a bit foolishly, we planned to relax things for Christmas, because Christmas being one of the main festivals in UK. And it doesn't happen only that those 2 days. In UK, we celebrate almost a month, and the celebration is less religious, but more about shopping, buying things, meeting families. So people started mixing, and there was a last-minute lockdown in several parts of UK because the European wave was very big. And then we got second wave. And thank goodness, the mass vaccination campaign by then was working quite nicely. So we had far less of a second wave than, or effect of the second wave than we would have had if we were not having that kind of vaccination campaign. Now, that is the stark difference between situation here and back in India, because as I understand, yeah,
50,000
as I understand that in India, the vast majority of population is yet to be even having their first dose of vaccine. So I think for me, that is the key. So learning from what we did, I just want to say, and you guys have been doing all throughout the pandemic in the first wave. However, I must say, I hear from my families, I hear from my friends in India, and it always worries me. When I used to call, when we were having a very bad first wave and we were having a second wave, तो मैं पूछा था कैसा चल रहा है, बोला इंडिया में तो खत्म हो गया, तो कोविड क्या तुम लोग बात कर रहे हो, तुम लोग वहां बैठ के इधर कोविड है ही नहीं. So it used to really make me worried, because being a man of science and, despite my all beliefs in good karma and religion and all those things, we need to take responsibility as individuals. And I was quite concerned. We were starting to see marriages, wedding ceremonies and big meetings, IPL going on, rallies going on, festivals and gatherings happening. So, it was just a recipe for disaster. So unfortunately, that did happen. Now, what we were sort of asked to do, and thankfully majority of the population did it, was self-isolating when there is any symptoms which will be of COVID, contact tracing, Maintaining social bubbles, so sitting in groups which always interacted with each other, limiting the size of the crowd, indoor and outdoor. Even till date, we are not allowed to gather more than 6 people. I've even forgotten how to keep a track of it, because I've just agreed to, just have the small family life for now, 3 of us. And of course, we go to work, so we meet our colleagues, and that's a different bubble. Working from home whenever it is possible. So that's another thing most of us have adhered to. We have been doing it. Even if we are working in hospitals, we keep in our bubble. Environmental measures, cleaning every surface frequently, and also keeping ventilation in the indoor spaces, which is very, very important. So it pictographically is showing, you all know about it. I don't need to tell anyone, but I must request and beg that even now, these are some of the most important measures to prevent further worsening of the situation. So physical distancing, strict hand hygiene, having respiratory etiquette. So, not, sneezing on someone's face, and using the appropriate face masks. Stay at home if you had COVID symptoms, please. Even if there's no lockdown, get a lockdown for yourself. And if you have direct contact with COVID cases, again, stay at home, monitor yourself. Try and keep in bubble, even if there is no restrictions. Please keep within a social bubble, a family of 2 maybe. Even if it's allowed, please don't go in big gatherings. I've just got a family I'm consulting where, they had attended a big wedding of one of their family members, and some of them are having symptoms. These are some things which we are now, it is ingrained in our brain that we should do it, but we are not doing it, unfortunately. Now, what can we do if there's widespread transmission? What is happening in India? So, again, the same thing. Stay at home, have a very big testing strategy. You have to test lots of people, trace them, and also isolate them. That is what we have been doing, and I'm sharing our story. And of course, if you are unwell, then you need to go and get help. Now, be mindful of the asymptomatic people. Now, you may think that COVID is only dangerous when someone has symptoms, but I feel, looking at the whole picture, it is more problematic when there is no symptom, because you are lowering your guard, you start mixing with people, and the people don't know about the infection, and the infection keeps passing along. You will ask me, oh, so when is all this going to end? Hopefully one day, but for now, I think it is very important that we follow these public health measures. So just before I end my talk, I just wanted to touch on a few things so that people know when to be a bit more careful. So these are the groups which have got higher risk for having severe disease or death. So be mindful if you have, or your friends, family, colleagues have any of these risk factors, including older age, being man, cardiovascular disease, so having heart diseases, blood pressure, diabetes, other kind of medication if you are taking, and that causes reduction in your immunity, lung diseases, kidney disease, liver disease, people who have had strokes, and obesity. So these are some of the classic cases or case scenarios where COVID can become much more aggressive. Okay, thank you very much for listening. We will take questions later on. I would now invite Dr. Rahul Sarkar, and I'll introduce him before I hand over to him. So Dr. Sarkar is, and as I said, an intensivist and a respiratory medicine consultant. He has got lots and lots of experience in actually managing patients. and he has got a great track record in all the main clinical trials. So the research work which goes on behind the, all the guidelines which tells you what works, what doesn't work. So he would now enlighten us with his point of view. Thank you.
Rajesh, if we can stop sharing your screen.
Yeah. Perfect.
Thank you, sir.
Hello, everyone. I'm Rahul Sakar. I'm just one of the respiratory physicians and intensivists that works with Rajesh, and I'm just trying to get my presentation across. But whilst I do that, I just want to say that I will generally talk about some basic treatment modalities for COVID-19, and we'll just generally talk people through, because we tend to get a lot of questions on various different lines of which ones are sometimes effective and which are not that effective, and you can probably club them in some groups, and I will try to address them through this presentation and see how that works. And given the fact that I understand from Rajesh that most of the people are non-clinical, but from various professional backgrounds in the audience, I am expecting that we can actually talk about some numbers and try to explain the questions through numbers and basic epidemiology, because that's important. Let's see whether the screen sharing works, first of all. It is not. Rajesh?
Yeah.
I'm just emailing it to you. Can you please share again the way we did it?
Sure. Are you sending on my Gmail?
No, actually we can't. So I don't know why I can't share somehow.
You are co-host, Dr. Rahul. You can share the screen.
Huh?
You can share the screen. You are co-host, so you have the power to share.
Can you see the share screen button at the bottom, Rahul?
The green button at the bottom.
Yeah. Okay. It's probably going to work now. Can you see my screen?
Yes. Yeah.
Yes.
Okay. Right. So what I'll try to do is I'll generate some stories and talk us through various different scenarios. Before I say anything, I think it's important to say that this has been a very fast evolving situation. So when we started last year, I remember talking about the news coming out from China in January last year, and I did a presentation for our ICU teaching in the department and for our trainees. And I look back on the date, and it was 21st of January. So it was from that time in 21st of January 2020 that I started to be interested in this. And then things moved so fast, it's unbelievable. We had various different ideas about how to treat viral disease. Then we had to change some of that. We had to change our how we organized ourselves. So that's a huge oops. I don't know what's happening there. So
you go on, sir. I'll control that.
Okay, so and that's why I put this on first, which is science is father of knowledge, but opinion breeds ignorance. So what I'm going to say is really not my opinion, but I would just share some of the certainties and uncertainties around what we know as professionals about the disease and how patients behaved throughout the pandemic. And until we can decide and agree that we don't know really much about this disease, we are never going to come to an agreement of how to manage the situation. And the fact that some people in general, which probably included us as well from time to time, decided that we know something and we know something really well, added to lots of bad practice throughout the pandemic. And our pledge should be that we shouldn't repeat that. One of the prime example of that was what happened with hydroxychloroquine. And we have seen last year lots of hype about this, and then it kind of vanished. And the way it was achieved was through properly designed trials that we all have been part of in UK, USA, and also in India to some extent. And looking at the results, looking at those numbers very carefully, seeing what helps and what doesn't help, seeing which drug I'm going to spend a lot of money on and which I'm going to throw on the bin. That's important, because in this time of uncertainty and in this time of stress, so many people are running around with for a drug which may or may not work at all, because we are all very desperate. And if this messaging was clear that some of these drugs work and some of these don't at all, it will calm things down quite a lot, because we have all got quite a lot to take. And we don't want to add to that by running after remedies and therapies which are not going to really work that well. So that's very important. So I plead ignorance. I think the best thing I have learned about this, and a lot of us, is that we don't really know much about this, and what we don't know, knowing that is important. Now, similarly, one formula that I follow, I would like to call myself a very low prescribing doctor and low intervening doctor in a patient's recovery. Sometimes you just watch and the patient gets better, and that's the best outcome. You don't even touch the patient. And to do nothing is also a good remedy, and it's very important. And my heart goes out to patients and their families across the globe who rely on lots and lots of remedies which are not going to cure them. Sometimes it's important to say that there is a natural way to recover, and also there is sometimes there is a role to accept that actually this disease is so vast and so powerful that it is not possible to get someone better, and to accept rather than to raise false hopes, which in a country like India can actually push a family to ruins. There is lots of data around which shows that intensive care treatment for lots of families with very expensive remedies can actually be up to 1 or 2 years of the income. And so we have to keep all of this in mind and see where we need to put our resources appropriately, so we get the best out of the resources allocated to treatment. Now, with that, I will just share. This one is just to show, this came out in Nature last year, how complex the disease trajectory is. There's lots and lots. I'm not really going to explain, but there are lots and lots of molecules involved, and that really leads to excitement amongst the scientists and doctors. Okay, block this interleukin 1, block this interleukin 6, and it will all fine. But it's not that, because there are so many other players, factors in play. So, if you have got a very strong cricket team coming to India, but you only had made a plan for one batsman, and then you bowl really well at that batsman, you will get that person out, but the other batsman will score the run, and your team will still lose. So it's exactly that situation, that just one single remedy is not a magic answer to the whole disease trajectory, which we have learned with other diseases. But of course, out of the desperation, we are trying so many different things. With that, I just want to explain what happened to one of our patients. Don't worry about the numbers. I just, this particular slide, a couple of slides were made for doctors. But I will just talk you through the patient's journey. This person was a healthcare worker, works in our hospital, came in really, really sick with COVID-19 last year. And on day one, really, really bad. So got intubated or ventilated very quickly. And then really, even ventilation wasn't working very well. So we had to put him on his belly. So you must have heard of prone ventilation. So we proned him, and then things got a bit better. And then day 2, we could put him on his back on supine position. But then day 4, more or less stable, lots and lots of therapies, different fancy ventilator strategies. We actually referred him to ECMO. ECMO stands for extracorporeal membrane oxygenation, which is like a lung dialysis. Your blood goes past the oxygenator and then comes back through with lots of oxygen. And that was not needed. And then we put him on a regular protocol. And that's day 4 I'm talking about. And then day 5, bit of kidney problem, again proned, and lots of other fluid strategies and so on. And then day 6, it was looking like the patient was looking better. But day 7, we performed a thing called tracheostomy, which is a tube through the windpipe at the front of the neck. And then he had lots and lots of cough, some liver problem. Day 8, still nothing much happening. He's waking up now, obeying commands. But ferritin is an inflammatory marker, which is being done a lot. Some of you may have heard of. It's still quite high, and overall not very good. Day 11, and by this time he had a very distended abdomen. He is still coughing badly, kidneys functioning, UO is urine output, some problem with his heart, then another line inserted. So we started some other form of sedation so that his cough is improved. Day 13, abdominal distension still carries on. TPN is total parenteral nutrition. Now we whatever feeding we are giving him through the feeding tube wasn't being absorbed in his body. So we had to give him his nutrition through the vein. His sodium, our normal sodium is up to 145. His sodium is now 155. So other problems coming in. So overall, he has gone through the initial phase of bad COVID, but he's not really getting out of trouble. And if we take one wrong step here, he dies. So it's like walking through a really slippery pitch, and you are not allowed to fall. So you have to take every single step really, really carefully. And that is usually obviously done by doctors, nurses, and nutritionists, and so on. And this is his CT scan. I'm sure a lot of you may not have seen the CT scan. All it is this bit is the right lung. The thing in the middle is the heart, and this is the left lung. Normal lung looks like a black area. That's normal. Black is air, so a lung is full of air, but solid is white. So this part of the lung is solid. All of these parts are solid. This is solid. So you can see how much of the lungs are affected, and this is after quite a while. So he's not really getting better, and this is now after 2 weeks. And this is his CT scan of his belly, abdomen. So you see very dilated loops of his bowel at that point. So his abdomen is misbehaving. His chest is not getting better. He's still battling it out in the ICU. And with him, we are being very careful with every single thing we can do to make sure that he doesn't falter. And day 15 now, another antibiotic we have started because some of the secondary infection, bacterial infection now settling in. Day 16, still needing very high oxygen, still prone. So the battle goes on. And now he's on an antifungal therapy as well. Some of you may have read that fungal treatment infection is quite common in COVID patients for various reasons after a while, not in the first week, but after that. So lots and lots and then his blood has another bug coming in as well. So by this time, he's kind of becoming a culture media of various different bacteria growing inside his body. And then secondary infection, which is common in patients in ICU, we start trying to fix those things on an ongoing basis. And then we had an echocardiogram. Heart is not that bad. We have done a lung ultrasound. That's not so much of a problem, but the solidness of the lung is obviously there. The ventilation goes on. BiPAP is a mode of ventilation that goes on. If he's needing by this time 90% oxygen after about 3 weeks, which is huge. And day 19, still prone and lots of antibiotics. Day 20, this is a paralyzing agent. It's which he was on. Another fancy ventilation mode. The story goes on. And this is a scan at that point. Again, lots of white patches in both the lungs. And so the point that I tried to make through that story is that eventually he went home after being in ICU for about 5-6 weeks. And for all of that time, he could have died in every single day if something was done wrong. By something, I mean, he had to be he kept under good nutrition. He had to be on the right antibiotic. He had to be moved from right to left and left to right again so that he doesn't get pressure sores every 2 weeks. We had to change his lines every now and then so that he doesn't get more infections. We have to pick the right antibiotic through lots of various cultures. So, you know, there is a saying that you are as strong as your weakest link. So if we did everything right, but didn't do one thing pretty well, then the system will falter and he would die. And of course, we have lost some patients as well. And we, you know, sometimes I don't think any team in the whole world would claim that they have done every single thing right for their patients on a consistent basis for hundreds of thousands that they have seen. But the point I'm trying to make is, for very mildly affected patients to very severely affected patients, you have to take the right step at the right time. Just the drugs do not matter. There is a holistic care about all patients as well, and that has to be done well. And that attention to detail sometimes is lost in the current state where things are really, really busy everywhere. In New York, when they initially started, the 90% of the patients, 88% of the patients on ventilations were dying, and that's unheard of in an advanced healthcare system. So that's the important thing. And here we are seeing what happens. So as the symptoms onset, there is about a week now that you are not really feeling that unwell, and from 5 to 7 days you're starting to feel unwell, and people come to hospital, and then shortness, breathlessness is a problem then, and then some people get really severely affected, which is acute respiratory distress syndrome, which is the lung involvement, and then after that intensive care unit admission and so on, and some people would then recover. So the point is, then a lot of patients will be at this kind of zone where they just start to feel unwell and a bit of fever. What do you do about them? Do we throw every single therapy at them, or do we not do it? And I try to address that issue in the next 5 or 10 slides. So this is the picture looks like as to what happens. So in the initial part, in your body, lots of virus is multiplying. It's a total farmland for viruses. They're just growing from millions to billions, and the body is trying to fight it. And then after a while, the viruses die. And in fact, there is a very good evidence that after about 10 to 12 days, viruses are not really there in live form in most people. So there is a thing that happens a lot, that people do get repeat PCRs, repeat swabs, and swabs continue to grow, show that there is some viral particle in the body. And some studies have shown that whilst your PCR might be positive after 30, 35 days of symptom onset, when you actually culture it to see whether that little viral particle is still alive or they're just dead particles flying around, they have not seen that actually there is lots of live particles. After about 12 days, 13 days, most of the virus is gone. What is remnant is like the dead bodies of the virus. So by 12 days, the virus is gone. And after that, the body is trying to fight the remnant of, what the virus has started, trying to come out of that. It's like a battleground, and lots of bystander harm happens to the body and organs because of when the body tries to kill the virus, it harms itself. And in some people, it goes on to a automated, really bad cycle where the body is continuously damaging itself. And at that point, of course, just killing the virus would be like firing a bullet to a shadow, because the virus is gone by the time. Around this time, there is no virus, but the inflammation in the body goes on. And at this time, what we need is some anti-inflammatory like steroids and so on. And again, not in everyone. And I'll just show that next. So the main point is, by the time the patient comes to a doctor, a patient is symptomatic or in hospital, most of the virus is gone. So just to try to kill the virus doesn't really help hugely. And there is quite a bit of evidence of that already that has built up. So remdesivir being an antiviral therapy, we don't really have much evidence that remdesivir does save lives. So and then with that, I also want to touch upon this before I show where the steroid etc. can be harmful or helpful. That this is a CT scan. We are seeing lots of CT scans are being done, and you see so many different. I purposefully brought this up. But I know that you are not used to see CT scans all the time, but I'm sure you can understand if I explain. So again, the middle bit is the heart, and the black bit, that our right is patient's left and our left is patient's right. And you can see that various different involvement of the lung tissue can happen. The black is normal, and all these arrows are towards the abnormal white patches. And some people have lots of white patches, lots of solid white areas. Some people haven't got that much. And a lot of people with a mild viral illness will have these mild patches, but usually just gets better. When I get a mild fever in the winter because of whatever virus I have caught, if I do a scan of myself, I would probably find some small patches like that. But we don't do it because they're diseases that we are used to fight. Given that COVID is a kind of unknown enemy, people want to know everything about COVID as it happens. And that's why the keenness of doing the scan is there, and which is understandable. But in the situation where there is lots of COVID around, in people who are well, there is no point in trying to find out very mild abnormalities like that, because they're just there. What do? You have either got it or you don't. The treatment strategy is based purely on how the patient is. That has been the cornerstone of therapeutic strategies in most of the systems, to be honest, where people have tried to do things rationally. And I wouldn't put much time on that one, but this one I wanted to. I was just telling one of my colleagues who is listening to this. I know Dr. Divakar. I told her before this that I will try this once, because I teach this to medical trainees, and they get it. I'm sure you get it. You will get it as well. So I'll give it a try. So what is the chance that a CT abnormality will have a good chance of picking up? And if there is a CT abnormality in a patient, how reliable that is? That's what the point of this slide, this one and the next one. I'll show you, and I will explain this point by point. Just take this as an academic exercise. I'm sure you will come out enjoying this. So I am imagining a village where there is a population of 1,000, and in that population, say in December last year, December 2020, 10% people had COVID. So 100 people had COVID and 900 didn't have COVID. And the CT scan has 80% chance of picking up in COVID infection if you did it. In 20%, it kind of misses it. CT is not kind of good enough, and say it misses the thing even if you do CT in all of them. And the village leader decided that he's going to do the scan in all the 1,000 patients, all the 1,000, not patients, all the 1,000 population, just to know everything about everything. So he will do CT on all 1,000. So that's the scenario we are talking about here. And because 80% patients are picked up through CT scans, we see that here CT positive 80 out of the 100 that actually have COVID. And then of course CT picks up many other things as well. So, and therefore, because there is some white patch in the CT doesn't mean that it has COVID, which we call like false positive. The 10% patients get picked up falsely. Something else is going on, but CT has picked up something. So 90 out of the rest of the 900 is showing something. So of all the patients who had CT positive, which is 170 patients overall, 80 of them had COVID. So 80 out of 170, 80 times 80 divided by 170, that is the positive predictive value of CT scans in that scenario, which is 47%, right? So even if you didn't understand, you just know that I'm sure you understood it because it's not that difficult. Say 47% is the positive predictive value of CT scan in a situation where 10% of the population have COVID. Now see what happens. Now you are the neighboring village leader has now learned that, okay, this village has done it last December. Now this is April. I will do it in my village. All 1,000 villagers will have CT scans, but by this time, 40% of the villagers have got COVID because things have gone higher in India by this time. And now we remember that 80% pickup rate in CT scans. So 320 of this 400, which is 40% of the whole population, have got CT positive, and people who do not have COVID, they have some false positive rate as well, exactly 10% like before. So 60 people without COVID also showing some CT changes. Now see what happens. So 320 out of all these 380 people have got CT positive results. So what is the positive predictive value of COVID, of CT scans during this time? It's 84%. So the same test results, depending on what background scenario you are doing it, can be differently useful. In this situation, the positive predictive rate is 84%, and previously it was 47%. So the point I'm trying to make is in a situation where a lot of people do have background in prevalence is really high, that you know that every other person has COVID, just doing a CT scan is really not that helpful in picking up disease. In this scenario that's going on in India, where I come from, Calcutta, if you tell me that someone has fever, if you tell me that they have a bit of a cough, I would say that that person has got 80%, 90% chance of COVID without doing a test. Of course, we have to do a swab test, but why CT scan? Because CT scan is like 200, 300 X-rays. And sometimes the CT is happening repeatedly in various people. And that increases. So a patient who is 30-year-old, that person having 2 to 3 CT scans will be like giving them 600 X-rays. And that person has another 50 years to live. Their cancer risk will be a lot higher. But what have we achieved by doing the CT scan? We knew that he had COVID, and we just still know that he has COVID at the end of doing the CT scan. We are no more richer in terms of our knowledge about the patient by doing a scan. We know that he has COVID. What are we gaining? There is a gain to be had in patients who are in hospital, who are in ICU, who are more sicker, because sometimes we as lung doctors, we have as intensive care doctors have to identify various patterns of how the lung is affected. You know, what is the type of lung affection that has happened, so that I can then tailor my therapy accordingly. But someone who is at home, or someone who is just on 1 or 2 liters of oxygen, they will have all those mild patches. What's the point of knowing them? Sometimes not knowing them is good. One of the best medicine teacher I have been taught by, he used to say, sometimes ignorance is bliss. And I would rather be living in a blissful ignorance about those small patches rather than knowing, because you know that, okay, CT severity score 8 out of 25. Oh, I'm really unwell. But it might not. You might be sitting at home with a saturation of 98 or 97. What's the point then of knowing that CT severity score of 8 out of 25? You have spent 7,000 rupees. You have now had the 300 chest X-ray radiation, and you are now more anxious. All you have done is to lose. You have not gained anything. So that's the argument I'm making. It's no one to take. That's the argument that I give to that's the advice I give to my friends and family. I hope that I at least made the argument. And this then brings us back to the most contentious of all issues during the whole pandemic that I consider. Now, having spoken to doctors in America, here, India, and some other places as well, what do you do with this steroid issue? So recovery trial was built in a matter of a few weeks. Last year in UK, we took part. We recruited 500 patients from our hospital itself. The whole trial has recruited about 40,000 patients overall. And essentially what this shows, I want to show you this because I know that a lot of the audience are not medical, but it is easy to understand. Now, see what happens. All participants, if we look at the panel A at the top left, what you see is that the red line is for the dexamethasone is a steroid. Red line is patients who have been on dexamethasone. So of course they're kind of the red line being lower than the black line means they are better off after having steroid. But very importantly, now look at the bottom right panel. Bottom right, the red line goes up. And who are these people? That means the red line, which is dexamethasone, which is steroid, can be harmful in patients who do not need oxygen. So if a patient who is not on oxygen is given steroid, they die more. Their rate of harm is more in patients who are not on oxygen. And as you see at the top right panel, if someone is on mechanical ventilation, people in ICU, they do get better a lot more than other patients. So essentially the summary of this is the sicker you are, the more oxygen you are on, the more support you are on, you are more likely to be benefited by a steroid. But if by default, everyone is taking this, no matter how sick they are, maybe someone is not sick at all, they just got a bit of fever. If a lot of them did take steroid, there is more chance of harm in that group. And even in people who take steroid, do everyone get better? Answer is no. That if you look at that, what I've written in the text, so dexamethasone reduces mortality from 25% to 22% in that trial, which means that essentially you have to treat 33 people to save one life. 32 still die despite having the steroid. So just one treatment does not cure everyone, and you have to treat quite a few people to save life. But if in ICU patients, if you only have to treat 3 people to save one life. So that's obviously a lot more effective in the sicker group. And that's obviously true, because why this is happening? Because we have seen that white patches in the lungs, which is inflammation. The more white patches means more inflammation. More white patches means the lung is full of fluid. And that's when steroid can reduce inflammation and can help the patients. But if those patches and if the oxygen is not needed, that means the inflammation is not there, then steroid is not going to be helpful. In fact, it will reduce your immunity and the viral will replicate more and will harm more. So this is very important that yes, steroid has saved lives, but not in everyone. And then there have been other treatment, and this is the same thing which is shown. So you see no oxygen received has got a more chance of death to some extent. And that's very important to understand. And then there are many other trials that have happened, but mostly all of these trials, I'm not going to show you, into detail, but all of these trials are mostly done in very sick people. They are not in patients who are sitting at home and taking lots of steroid. That is not what has happened. And we have seen, again, in recovery, we tested hydroxychloroquine. See, the lines are quite close to each other. It hasn't helped. Same with azithromycin, a lot used in various settings, including India. It hasn't helped. It actually can have underlying side effect profile, which may not be good in especially people with heart disease and so on. And convalescent plasma, again, has not been helpful in recovery trial itself and in some other trial. And then we found this drug, that tocilizumab, which saves lives. And again, this is a very potent anti-inflammatory drug and only to be used in more sicker patients on certain categories, and giving it to everyone doesn't help. For example, there is a trial done in Brazil where it has actually shown harm. So this has helped, but should to be done in a very careful manner. And ivermectin, this is again very widely used drug. It is in Indian guidelines. It's fairly harmless otherwise, but only was taken from a study which was done in 72 patients, 23 in 2 arms and 22 in the other arm. And it only showed that ivermectin reduces viral clearance. But if we then looked at how many patients had fever, etc., after 2 weeks and so on, people who are on no therapy at all had less amount of fever compared to ivermectin arm in that particular study. Zinc and vitamin C, very well designed study. None of that has been shown to be of any benefit, but fairly harmless if someone wants to take take them, probably fine. But I'm just hitting home the point that a lot of the therapies are being done in desperation rather than from a lots of evidence base behind it. And ivermectin, the Dhaka study, I bring this up is again. So these are the three groups, and you can see that in ivermectin arm at day 7, after a week or so, fever, 82% patients who had ivermectin had fever, 73% with ivermectin doxycycline had fever, but only 70, much lesser than that in the nothing, who had nothing had fever. So what is important to me? What is the symptom of the patient? So overall, there is nothing, not a great benefit that was shown from the Dhaka study, but it has shown that viral clearance is higher if you give ivermectin. But we have shown before that simply clearing the virus doesn't really matter hugely. And then this is Solidarity trial, which is the biggest trial of remdesivir, and it has not shown it saves life as well. You can see that these lines are fairly close to each other. Again, for the same reason that in viral diseases, Dr. Hembram treats HIV, which is a chronic viral disease. In chronic viral disease, HIV, hepatitis C, killing viruses help. But in acute viral disease, killing viruses don't help for the reason I have explained before. My and our philosophy has been, whenever a doctor cannot do good, he must be kept from doing harm. And harm can come from the therapies themselves. And we have to use our therapies judiciously. And natural forces within us are true healers of the disease. I am strong believer of this, that if a patient gets better, it's up to the patient's background physiology. We are just bystander. We try to comfort them. We try to care for them. For example, patients, when they come to hospital and on a tight-fitting BiPAP mask, they can't brush their teeth. And if he cannot brush his teeth, then the mouth is full of bacteria, and that will be going down towards the lung and cause pneumonia. So my job and the nurse's job is to make sure he washes his mouth well. Otherwise, the secondary hospital-acquired pneumonia will go up. So let's focus on those basic care that we can do, and then let's not claim that just some magic therapies will make all the patients really, really well, and let's reduce the harm. And I use this quite a lot. Say, let's imagine our best batsman in the world is playing with the school team, and Kohli, by all account, is the best for some years and probably will be best. But say this team is now playing, and because we have the best batsman, I am hoping that I will win against this team. Will it ever happen? It will not happen. That team, despite having the best batsman in the world, will still lose. And we need an overall better team. And that's important to know, that just one magic therapy doesn't cure the disease. If we take that magic therapy as Kohli equivalent, and not only that Kohli will not help, but where does Kohli bat? Does Kohli bat in that team in number 1 or number 6 or number 11? So unless I use my batsman, which is my therapy, in the right time, that is not going to be helpful. I have to pick up the therapy and use it in the right time. And all of that has to come together, then a patient survives. And other than that, just having lots of therapies would not work. And that's why healing is a matter of time, but it is sometimes also a matter of opportunity, where I use my therapy, and whether the patient gets the basics, whether the patient gets the basic opportunity to have oxygen at the right time, have a hospital bed in the right time. That's more important. Oxygen saves more life than any of the drugs that we discussed, and that's why we need to make sure that that happens. And with that, I'll finish.
Thank you, Rahul, for a proper, detailed account. I hope this has gone down nicely with the audience, and that they understand a bit better what we sometimes want to say very loudly, but we are unable to say very loudly because we don't want to hurt the feeling of our colleagues elsewhere. Now, I will summarize Rahul's point and we'll go through the questions. We've got quite a few questions. So Rahul and I, we are on the same page exactly. So Rahul has very nicely showed what should be the need of image or like doing tests like CT scans and multiple CT scans. You know, that has to be really done carefully and not sort of Dr. Self, which is the most common doctor in India now. It's called Dr. Self. Everyone goes to the radiologist and get their CT scan as soon as the swab is available. That's not what we would do or we would advise. He has also very nicely covered about this use of steroid, where it works. So please don't start taking steroids immediately and buying it over the counter from the pharmacy as soon as you get a swab positive. It has got particular indications. Rahul has very nicely touched on some of the antibiotics. He showed some slides about doxycycline, azithromycin, ivermectin, and also things which are very commonly being prescribed like the zinc, vitamin C, and some of them are fairly harmless. So okay to take it, but not give you false assurance that it is going to work, but some things are going to be harmful as well, which he showed in his slides. Then about some of the very unfortunate incidences we see where people are running around looking for plasma donors and paying thousands of rupees. Sorry, I talk in pounds, thousands of rupees for something which may have no effect at all. So it has to all be done very carefully. Now, going to some questions which have been posted, and I'll ask Rahul to participate, please. Rahul, you're there, yeah?
Yeah.
Yeah, okay. So Mr. Jitendra Sethia has asked, should we keep oxygen concentrator at home for precautionary measure? If yes, what make and whether 5 or 10 liters? Do you want to go first, Rahul?
So there cannot be one answer to this. So oxygen concentrator traditionally has been used mostly for chronic lung disease patients, but in this current situation, we are seeing that it is something that people have kept, but from a health system point of view, there are two sides. So one is the health system point of view, and the other one is individual point of view. And of course, like we have seen, the richest person in our country has got a hospital in his house. So if we can take that approach and create a mini kind of healthcare center in the house, and that can give us reassurance. On the other hand, the problem with this is that a person who is needing oxygen at home may be in a situation that, and we have seen this, that a patient who is needing 2 to 3 liters of oxygen and their oxygen saturation is 90%, 91%, and suddenly there is a drop very quickly. And for whatever reason, they're not really responding to the oxygen that can be given in the 5 liter or 10 liter, whichever concentrator you use. So there is a very sudden drop. So if a concentrator is at home, there is a chance that the person will be reassured that, okay, I've got some oxygen source at home and I'm carrying on. If there is a sudden drop, then it will not be possible to get the right sort of medical support that a hospital can give. So the absolutely right technical answer to the question is the oxygen should be available in a community setting. In say every little apartment building or every little block can have a small oxygen source which can be used for the patient when they're waiting for a bed. But as soon as the patient needs oxygen, that patient should be directed towards hospital, because things can happen very quickly, and simply having an oxygen source will not help. And but in the given scenario, getting a hospital bed might take 6, 7, 8, 12 hours, and to buy some time, it may not be a bad thing for every local community to organize some small oxygen source which can buy some hours for a patient in the locality. But to have that at home can buy some reassurance, at the expense of not having the right medical intervention if the patient then goes down very quickly. Okay. Anyone who needs oxygen should be in hospital.
Thank you, Rahul. That was very comprehensive. I am taking a question from Naresh Lokhotia, and that is, what are the chances of third wave and how it's going to be different from the second, and what are the precautions necessary so we don't reach them? So I'll take on this question, and I would say it is a very real chance of having a third wave. It's not a fantasy. We have seen it in other diseases, other viruses. So it can happen. And COVID is proving to evade some of the interventions we have, some of the treatments we have. And it may even evade some of the vaccine we may have. So the question, the issue is that, can we relax till we all get, oh, there's mass vaccination across the globe, and we can reassure ourselves that the new mutants, the new varieties of viruses are not going to evade those, or circumvent those, or escape those vaccines, then we can say, yes, we have come to an end. So yes, we should continue to be vigilant.
I'd like to add a point there, which is that there was a paper from Harvard last year, which predicted that some social distancing will be needed until 2024. Going forward for various reasons. And one very important thing is, even if the whole of the population was vaccinated, still the social distancing, masking, etc. will need to be carried on for a long time with very strict surveillance of the disease in terms of new mutants coming in from other countries and so on, because we have already seen the new mutants are not always very responsive to the vaccines. So it will go on for a long time, and most importantly, social distancing and masking is very important going forward, despite widespread vaccination.
Thank you, Rahul. That is very, very important to, yes, the preventive measures have to be continued for a long time. And I totally agree with you on that. So Rahul, we've got quite a few questions on the vaccine. So I'm going to club them together. The questions are related to, which vaccine should be taken. If I get the first, when should I get the second dose of vaccine? And if I get Covishield, can I take Covaxin or Sputnik? And also there are questions about what would be the gap between being infected, having recovered, and then taking vaccine. So I'll tell a few things, and Rahul, you can please pitch in and complete the scene. So basically, from vaccine point of view, I think most of the vaccines have done quite well in clinical trials, and whatever is available is more important than which one, I think, at this stage. So yeah, go for any vaccine. What about taking one vaccine and then following up with another vaccine? Studies are, as in another type of vaccine, studies are underway. We don't have the full answer to that, but chances are that the two types of vaccine would still do good rather than not having a second dose. Would we need third dose? Well, time will tell us, but it is likely that we might need a third dose. If you have got infected, what is the good gap? So after recovery, we in UK would usually say, wait for about a month. After that, you start your vaccination. It is tricky if you have already had a vaccine, then get an infection. And with generally, one point I wanted to make also clear that a lot of people have been saying that they go and get vaccinated and they are getting COVID infection. Having seen all the footages in India and all the way the vaccination program has happened, one of the problem is that when people are going to get their vaccine, they are mingling with lots of other people in that same vaccination center. There are hundreds of people there. And even if few of them have got it, they have got very likelihood of spreading it around. So people come back and after 5-6 days, they have developed COVID. Now that is not due to the vaccine. That is simply an infection which happened when you went to the vaccination center. It takes about good 3-4 weeks before you are protected partially or fully, as fully as can be from a vaccine. So you have to continue taking full precautions throughout that period and afterward as well, even after you are vaccinated. But yeah, don't confuse vaccine causing COVID infection. That doesn't happen. Anything else, Rahul, related to vaccine you might want to add?
Yeah, I just want to add a few points. Number one, there have been a few myths going around that you have to stop various different drugs during the time that someone takes vaccine. No need. The only thing is if someone is on anticoagulation, they can just stop that for one day. But even aspirin, etc., all the other blood thinners, heart tablets, everything should be taken exactly as it is. Because a lot of times elderly people or people above 40 in India, lots of high blood pressure, high diabetes, etc., can absolutely safely take it. Number two, after someone takes vaccine, it takes about 3 weeks to start the immunity to build as a result of that. Of course, if that person is exposed to an infection within that time frame, they will catch the infection in a high transmission situation that is in India right now. And therefore, a lot of infection that is happening is not due to the failure of vaccine. It's just the nature. There is a blind spot for the vaccine for 3 weeks, during which time, if you are exposed, infection will happen. And secondly, I have just recently, yesterday, came across this thing that apparently a doctor has sent out a video or an audio that says that we are giving viral load through vaccine. And that's why the infection might be worse. No virus, live virus is being given to the vaccine at all. It's only a viral particle in whatever technology it is. So vaccine is absolutely safe and should be taken in whatever shape or form and whatever is available locally in a safe manner. So if someone goes to take vaccine right now, they should wear an N95 mask, given how crowded the vaccination centers are. And someone said, oh, this vaccine is better or that vaccine is worse. A friend of mine, and I said, look, if at the moment you can imagine a tiger is going around your community, and you think that if you are wearing a big armor through which lots of bullets are coming out all the time, you will be safe, and that is your vaccine. Yes, that's the best thing. But in absence of that, the best vaccine. But in absence of that, you have been given a little revolver through which you can counter the tiger, and those are the lesser vaccines, for example. Would you not take it? Of course, I'll take that revolver and go out instead of being bare-bodied or bare-handed. So any vaccine that is available, you should absolutely take it and go to the vaccination centers in full protection in terms of N95 mask, because they are not socially distanced. And of course, that can be a risk. So
thank you, Rahul. Someone has asked, how long does it take to show symptoms? Suppose I don't have symptoms of COVID, might I be asymptomatic positive? What do I do to assure that or reassure myself? And if someone was COVID positive 3 weeks ago and developed pneumonia severely and has got all the other problems, like diabetes and all, do I take care as neighbors sharing a common wall? So there are two aspects of it. One is about, how long does it take to show symptoms? So Dr. Sarkar has already addressed that it's about in the second week mostly, but that is the severe symptoms. Initially, fever and all can happen quite quickly. The asymptomatic people, there's nothing to be done. You don't have to unnecessarily be tested, only if you are in contact with someone who is known positive for COVID. But yes, at the moment, with such a high prevalence, so many people having COVID around you, you should just take that usual precaution of mask, gloves, all the social distancing. What about caring for someone in another, someone who is next door? That's a very sort of individual decision to make. And I would say with extreme care and easier if you are already vaccinated, then it kind of...
I think they mentioned that 3 weeks from their symptom onset. So after 3 weeks, as we discussed before,
yes, sorry, I missed that. Yes,
people are not infective after 3 weeks unless they're significantly immunosuppressed. Again, there have been studies on patients on chemotherapy or other sort of leukemia, etc. They can be shedding live virus for up to 32 days. But if for immunocompetent, like normal people, they would not shed live viruses after 3 weeks. So it's okay to look after them during that time. But there is no harm in, just make sure when you're going inside that they're wearing a mask and things, but the chance is really negligible if that timeline is 3 weeks.
Yeah, and so thanks Rahul for picking that up. I'd overlooked that 3 week. There are some queries about the test, because lots of people are just self-testing and they're repeating and trying to achieve a negative test. So I can tell you from my experience as a sexual health doctor as well, we have conditions where we know that once we have tested positive for a particular illness, the bacteria or virus which is there, and we pick up their genetic material, we pick up their DNA or RNA, and we test that. Even when the bacteria or virus is dead, those DNA and RNA, which the machine picks up to call it positive or negative, remains in the body for a long period of time. Some viruses more than others. And we know that the same can happen with COVID. And therefore, and also not every time it will pick up the, even if there is live virus, not every time it will pick up. And if there is no live virus, it can pick up some wrong signals. So no test is perfect. It has to be kept in the context of the patient, how they are presenting. But we, in only few circumstances, will continue or do periodic tests. Certainly not in the community. There's no requirement in our guidance that we should have a second test to prove that we have become negative. All we do is 10 days. Now, it used to be 14 days, but now 10 days of isolation, and we are considered as non-infectious, as in we can't pass it on. And we, if there is no particular medical need, tests are not repeated. Would you agree with that, Rahul?
Yeah, absolutely. Like we discussed, if two tigers have fought with each other, again, going back to the tiger allegory, then both of them are dead, but lots of tiger blood is flying around, and someone tested the blood and showed, oh, there is a tiger blood here, don't go there. But the tigers are dead. Yeah. So it's exactly like that.
I like your tiger analogy. That shows you are from West Bengal. Okay, so I've got quite a few. So someone has asked, which is certainly something we are talking a lot in our circles, in our medical circle. Someone has said, oh, can we deliberate a bit on the black fungus? And basically by black fungus, they're meaning mucormycosis. So Rahul, do you want to give it a go, please?
Yeah, so when we are talking about the patient we discussed, you must have, I mentioned that he was on antifungal therapies later on in his stay in intensive care. Why was that? That he was on obviously some steroid, and steroids reduces the immunity of the person. And when immunity is down, funguses are there everywhere, fungi are there everywhere, and that can settle down in a lung, and that can invade the bloodstream and cause lots of trouble. And if we look at how much steroid was used in all these trials that we talked about, let's take a drug, prednisolone, for example. In prednisolone, we change how much steroid is used in prednisolone equivalent, and mostly those prednisolone equivalent dose was 30 to 40 milligram in all the trials. Now, when I talk to people in India and also here as well, we have done something closer in some patients, they have got prednisolone equivalent of 300-400 milligram dose. So 10 times the dose of prednisolone that was, or dexamethasone that was used in various trials. So huge amount of steroid is being used. And at that sort of level, all immune function kind of gets dampened. And therefore the body can't fight the fungus. And that's why it's quite natural that after a while fungi will set in, and in lung disease it can happen. The most important thing is that it doesn't happen in patients who are at home. Someone who had a fever for a week and taken a paracetamol or whatever and then got better, it's unlikely that will happen in them. It will be unlikely to happen in patients in hospital who have had 2, 3, 4 liters of oxygen. It is more likely to happen in patients in ICU. And in ICU, doctors are very aware of this situation, and they are testing for it all the time. They have to do the right test. there are various different tests that can be done, and they have to do right tests. So in terms of general population, I don't think that's a huge risk at all, unless someone has just taken out of abundance of precaution lots and lots of steroid for 2, 3, 4, 5 weeks at home, which was not needed in the first place. So if mistreatment or maltreatment has happened, then of course it's a chance for patients at home. Otherwise, it's a thing to happen in ICU patients. And there are lots of, it is a reality, it is happening a lot. And all ICU doctors across the world there's a name CAPA, so COVID-associated pulmonary aspergillosis. And people are aware of this, and they're testing for it all the time. And we have seen that if this happens, people do have fungal particles for weeks afterwards, and we have to then treat them for 3-4 months of antifungal sometimes. But those are basic.
The argument is about indiscriminate use of nebulizers with the steroids, or letting the oxygen pass through not so clean water at home, which may get into the respiratory system, because lots of people are practicing this at home. That's what many people are putting out in the social media. Do you concur with it? Do you think there is a mileage in it because they're seeing increased prevalence of mucormycosis that doctors are reporting? Or is it that we have just been now too vigilant and looking out for it, and it is not relevant for medical point of view?
So let's take an example of a 50-year-old man who is a bit diabetic. Say, again, I'm from Calcutta, say in Calcutta, and then his oxygen saturation dropped to 86%. And people decided, okay, he's not going to hospital. We are keeping him at home and giving him some oxygen, and the oxygen circuit is a bit dodgy and it's not that clean. And then someone decides that, okay, instead of giving normal steroid, I'll give him, high dose, 150 milligram twice a day of methylprednisolone, which is equivalent to 400 milligram of prednisolone or something like that. Then he gets it for 3 weeks. Of course, he's at risk of, aspergillus infection or whatever. But if the same person, if someone decides, okay, I'm going to take him to a hospital where normal clean oxygen is given and gave the right amount of steroid, then he's not at risk. But if often in patients in ICU, they simply by the way the disease is so severe, sometimes you just have to give very high dose steroid, and they are always at risk, and that's totally understandable.
Okay.
And respiratory circuits are very common source of infection in lung, but usually it happens in chronic lung disease patients. And acutely for a short-term use, it may not be that relevant.
Okay. Thank you, Rahul, for that. Vishnu, do we have some time for more questions to be answered?
Yes, 2-3 more questions can be taken up to 7:55. Then we can have some hand raise.
Okay.
They can be addressed.
Okay, thank you. So I've got some questions, which is again back to the vaccine. There's quite a relevant question. Someone asked, if someone got very high fever after 7 days of taking the first dose of vaccine and is now hesitant to take second dose, should that person skip the second dose because of hesitancy, or go ahead and take the second dose? Now, I'll have a first go by saying, firstly, I would like to know why that the fever is happening after 7 doses. As I was mentioning, one of the reasons I have found, especially in the settings back home, is that people are actually getting COVID while they have been going out to get vaccinated. It is quite unusual to have very severe illness lasting that long after taking the vaccine, but it is very common to have 1 or 2 days or even 3 days of having a bit of flu-like symptom, which happens with many vaccines. So yes, in that case, I would actually ask myself a question, is this COVID actually rather than the vaccine? Now, even if it was just the vaccine, should we be hesitant with the second vaccine? Unless you are having an anaphylactic reaction or something which is like really severe reaction to the vaccine, I'm sure none of us as medical professionals would say, don't take the second vaccine. So yes, I would very strongly advise take the second vaccine. And there are some questions about what will be the good gap between the vaccines. And there are some mixed message about Covishield, is it 4 weeks, 8 weeks, 12 weeks, and Pfizer, where they say, 4 weeks, 8 weeks, or 12 weeks. But I mean, there are differences between the government policy and what the data shows. But I think anything you do, if you do take your second dose, it just improves and boosts the efficacy of the vaccine overall. Minimum of 4 weeks, everyone is taking anyway. But anyway, I would say take vaccine between 4 to 12 weeks, whenever you feel like and whenever you're offered, but do take the second dose. Rahul, your comments.
And the second dose should be taken. There is some evidence that if they had a infection in the past and they had a first dose, the immunity is quite good, but it's not very universally done study. So we should just stick to the protocol and just take 2 dosage. A few bit of fever, etc. It's not going to be hugely important.
Yeah, problematic. Yeah, absolutely, absolutely. So there is another one, Rahul, which is quite commonly asked, and I get asked a lot as well by family and friends. So people are taking a lot of steam inhalation, and someone has asked, is this good for and effective in preventing or managing COVID and COVID symptoms?
So, if my skin is exposed to heat source for quite some time, what happens? The skin gets damaged. And because heat is bad, too much heat is bad, and skin is a much more tougher organ than our mucosal membrane inside our mouth or even in the lungs. So if I am exposing my lung inner wall, which are very, very delicate structures, to lots and lots of steam repeatedly, the chances are that those inner walls will be inflamed more. And where it used to be helpful is, say, steam is a kind of irritant and it makes you cough. So if someone has got lots of secretions inside the lungs and they can't cough it out, and they're very thick secretions, it traditionally kind of it helps to cough the mucus out. But COVID is a very dry disease. It doesn't cause huge amount of mucus plugs or mucus secretion inside the lungs. Even when we do a CT scan or we do go inside the patient's lungs with bronchoscope, etc., we don't see lots and lots of mucus being accumulating there. So in that scenario, it's hard to find how steam inhalation is going to be helpful. On the other hand, steam is pro-inflammatory. It will make lungs more inflamed. So I have asked everyone that has asked this question that don't use steam inhalation in the acute phase, and not to even do lots and lots of physio exercises as well in the initial phase. That can also be harmful.
Yeah, thank you, Rahul. I totally agree with you, and that's the same advice I'm giving family and friends back home. I've got a couple of interesting questions. One thing, Rahul, if you could very quickly shed some light on the risk of clotting through the vaccine, because that is one thing which people, we here in UK and in Europe have gone through that phase, but still a lot of miscommunication in the media. Can you just very quickly, succinctly tell in 2 lines, is there any risk? If there is there any significant risk?
There is a risk with the so-called the Oxford vaccine or the Johnson one, especially that particular technology can cause risk, but mostly it's in younger females. In the very latest one, I think that was from Johnson, that study, all of them were females. Everyone who had the vaccine, so younger females, and people who are mostly younger than 6. I think the average age is just around 40 from what I remember.
Right.
And the risk of having that compared to the risk of not having it and then getting a bad disease is way lower. So if the vaccine is there, then it should be taken if there is no other alternative. If there is another different alternative which is not causing that particular group of side effect, yes, for younger females, it is totally, acceptable idea is to go for the other one. But in absence of the other ones, it is better to take them. And in male, the risk is way, way, way lower. Anyway, it's mostly a young female situation.
And looking at the background risk of these clotting, as in what happens in general population anyway, there is only very marginal increase, isn't it? So overall, the advantage of taking the vaccines in our sort of way of saying is, far outweighs any risks, if at all there is. So yeah, we are very pro-vaccine people, or most of the medical community would be. There are some skeptics, but the data is there, and it shows that we can safely vaccinate the people. Okay, so I think we are having plenty of questions keep coming on. There's someone asked, what's the maximum period for taking second dose vaccine? I would say, at the moment we are saying, take it at least by about 12 weeks or so. And we will be sticking to that. What about measures for kids and younger people? Now, we know that this time around second wave, there is more younger people getting involved and having diseases. So perhaps it is something we need to be more careful about. What do you think, Rahul, about younger people?
Younger people, the main risk right now, fortunately, in this whole pandemic is the younger people have been well, fortunately, but they can carry the disease. So that's what their role has been mostly. And there is this thing going around that the third wave will affect younger people more. I don't know where that came from. So I want to see why they think that way, because there is no huge amount of current data that supports that. What happened in Brazil was that in Brazil's third wave in the place called Manaus, there is some young people got affected, but young people didn't mean like people who are 5, 6, 7 year old. They are mostly in their mid-20s, late 20s, early 30s, and so on. Very few people in low 20s as well. For whatever reason that happened, and now we are seeing more younger people because of an availability bias, because people at an older group have been vaccinated, and of course then the people who are susceptible are younger. In younger people, all they have to do is to keep doing the social distancing and wearing mask whenever possible. Other than that, there is nothing extra. Again, it just adds a lot of anxiety and panic. On the fact that the third wave will affect younger people more, I think will be unfounded. Only time will tell.
And in the same context, someone asked that, should they be, should they be vaccinated, and, what's happening in that side of things. So I can confirm that there are lots of studies actually already underway where younger people are being vaccinated. I think data is coming out slowly. I would anticipate there shouldn't be any problem or difference than adults. And maybe it will become mainstream later on in coming months and days, months and even years, mainly because they are less susceptible to the bad effects of the COVID. So they are lower down in the queue this time around. So yeah, watch the space. Someone did ask me, if they get first dose in India, the Covishield, can they get that second dose in UK? Looks like someone travels between the two countries. I can assure that if you are signed up here for vaccination program, when you come from India, and if you have taken a Covishield, you should be able to get your second dose. My hospital trust, they do the vaccination. Of course, it'll be good to have the proof of having had the first vaccine. If not, they would probably give you as a first vaccine in UK, and that will complete your 2 doses, and you may not have the second, the second vaccine, but because that will be the third one for you. So that would work. Just going through the question list, if there is anything else which we may have missed. Okay, I think the time is now nearly closing, so I'll hand over to Vishnu. Thank you everyone for listening to us so patiently, and apologies if we have hurt anyone, but please, this is what Rahul and I work and we believe in, and this is what data shows. I know practices are different. Make your own choices when you go home and when you are looking after your loved ones. But remember, the only way we know about facts is going as close to those facts and that is through research. And data is there. We know certain things. We'll stick by that. Thank you very much for coming today.
Dr. Rajesh and Dr. Rahul, one question came to me by one of the audience. They are saying, will the COVID will be eradicated totally, or we have to live with it?
That's $1 million question, or I should say a crore rupee question, isn't it? Although I must say crore is not that much in India anymore. So
you have to live with it.
Yeah, I think we have to be prepared that this may become like sort of some of the seasonal pneumonias we get, and they keep changing, and we take every year in UK we have to get vaccine in vulnerable people. So we have to be prepared. If not our lifetime, at least several years, we'll have to be prepared to have little modification. I'm very optimistic. We will get there. Well, already in UK now it's open. People are playing cricket. Their pubs are open, and we are meeting each other. So that day will come. But India at the moment is in between, they say, hard and the rock place. You are in a very difficult situation. We need to get out of that first, get as many people vaccinated, get the health system for once and for all better. Please invest in the health system in India, and then we'll be all, safer.
I'd just say one thing, that there was a term coined here last year, which was called infodemic. With the epidemic, infodemic was also happening. So with all the misinformation and so on. So what I'd urge you, whoever are still here with us, is that please don't believe or don't trust what we have said just here blindly. If you have any doubt or anything, just go back and look up. It's there. Even all these articles I shared are all on open access. You can just look up and believe only then. So WhatsApp is becoming a huge nuisance in this whole issue. Please don't believe me. Don't believe Rajesh. Only believe credible sources. You all have the resource right in your hand. Please do that. And keeping calm is really important. We all have our family members. My mom is now unwell as well. All of us have family members back home. So we all know how it is. But we can only do the right thing when we are calm and totally not panicking. And one thing is we have to, as citizens, probably as a doctor, this is my urge, is that all through the centuries and decades, we have invested so much in military and mighty powers, and we are happy to keep the military just sitting in the barracks parading every day and spend crores and billions on them. But we have not created a system in any country in the world where we have got a reserve bunch of doctors and nurses who can come on to battle a disease if there is one. We are not prepared to spend the billions on that to save our lives. How many people die of war? And how much we spend on the military, and how many people are dying now on the pandemic, and how much we have spent on keeping a reserve force for healthcare. We have to introspect, probably, which includes me, Rajesh, and everyone, that where does our priority lie as humanity, and that's quite important. With that, I'll finish.
Sir, one question, sir.
Vikas Bathwal has raised some question.
Sir,
Vikas,
sir,
please.
Suppose one person has got COVID in last September or October and got his first dose in April. What is the chance of getting COVID right now, sir?
Sorry, the question is, they had COVID last year.
Yeah.
And then they got the vaccine this year in March.
Yeah.
April.
March,
so if they had a disease vaccine in late April, they might have a second. They are at a risk of catching disease again, because, like I said before, that it takes about 3 weeks to develop the immunity, and depending on which variant they are being exposed to. And second infection has happened between September and now. I know people, again, in my acquaintances, and there are data there as well, that second infections are happening after about 5 to 6 months. And the second, the first dose of vaccine can act as a booster. It only depends on what sort of variant they are being exposed to following that, whether that will act against it. So there is no one single answer to that. Can they have it? Yes, theoretically they can.
Yeah,
but the chances
they should get full vaccination. That's what we would say.
Yeah.
And they should carry out the social distancing and masking as normal.
Yeah.
Thank you. Thank you.
Thank you so much. Thank you so much to both the doctors. Now this is the time to conclude the session. Before concluding the session, I would like to have a small event. One is the launching of our mobile app of our association, and one is the launching of the website of one of the social organization. First of all, I'd like to call upon Rahul Rungta. Please please on your video. Kavinder Chaudhary, please on your video. Vasudev Agarwal ji, please on your video. Mahendra Nahata ji, if in the program, please on the video. And I am sharing the screen very quickly. Rahul, Kavindra, Vivek Banka ji.
Yes.
Neeraj Agarwal ji.
Yes, sir.
Sir, this is the mobile app which we are launching from today. The committee is headed by the Kavinder Chaudhary chairman and all the committee members. Our mentor is Mahendra Nahata ji. This is especially for the purpose of our members, VIPCA Chartered Accountant Association, which is taking the leading role to organize this program. This is our login system. And this is the facility we are giving to our members to diffuse our various knowledge, legal and illegal, legal and other social information which you can share here. So now I thank all the committee members very well. They have worked hard for that. So I clap for them. Now the small event, second event is that Basdev Bhaiya, this is a basically pet thing of Rajesh. Rajesh, you will love it. Just this one. Rajesh, this is the organization which you have served many times. Even in Kolkata, once we have a program on with Vivek, Dr. Vivek, Dr. Vikash, cancer doctors, and he was the joint speakers. And Vivek Banka ji was the person to bring Dr. Vikash Agarwal, and it was done in the society of our where we live. This is the launching of the website today. Dr. Rajesh, you can see yourself here.
Yeah.
In the picture.
Thank you.
Dr. Rajesh Singhani, our IPP, was here. So I now announce the launch of this website and launch of the mobile apps. Thank you so much, all the viewers. And please give your guidance whenever we require to make it more powerful and more useful. Thank you so much. Now I hand over the proceedings to Vivek Bankaji for formal vote of thanks and their appreciation.
Yeah. Thanks, Vishnu. On behalf of VIPCA, I would like to thank Dr. Rajesh Hembrang and Dr. Rahul Sarkar for sharing his views on the topic, Care is the answer to COVID. What the renowned doctors deliberated on COVID in a very nice and lucid manner. Really, session was very informative and interactive. I hope all of us must have been benefited. Thanks a lot, sir, Dr. Rajesh and Dr. Rahul.
It was our pleasure.
Yeah.
Thank you very much.
Yeah.
Rahul sir को राहुल दादा बोल सकते हैं ना?
And thanks to all viewers. Thanks to all viewers for joining. And I would also like to thank all associations, organizations for joining and supporting us. Thanks, everybody.
Can I say special thanks, Vishnu, to our group in London who very, graciously have broadcasted it on another platform so that more and more people could get benefited. So thank you, Minal and the team. Vamsi was technical advisor, and thank you everyone in the IAL London. Yeah, thank you.
Can you little explain, Rajesh, how many Indians are there in the Facebook?
Well, this is a group. When I was very young, Vishnu, we used to have something called Orkut. And we created to party around and meet each other in London when I used to be there, nearly 18, 19 years ago. And that they later developed into a Facebook group. And I think there are, I don't know the exact number, but there are probably about 1,500 to 2,000 Indians who are in London who interact through this website. And there are many other fractions as well. So there are almost sort of, no, actually, I'm wrong. They were talking at, sorry, not 2,000, 20 to 25,000 Indians who are interacting through that. So yeah, and we have got direct access to High Commission of India and those kind of things, you know, so we do a lot of, we are sending oxygen concentrators from here to India. We have raising funds. So, you know, lots of people are doing little things, what we can. Yeah. So thank you.
Yeah, thank you, sir. Thank you.
Dr. Rahul, do you come to Kolkata?
Yeah, I come every day. And I was asked a question here that Vishnu Basia quite kindly asked that we should come back and work there. I have actually sent lots of message and written directly to the government as well that please allow us to come and work or be involved in any teleconsultation facility or whatever we can. You know, if we are allowed to be part of the system and serve, we are very happy to serve. Absolutely, what's going on there? It's painful to watch from a distance.
Vishnu, can I invite Minal, who is the most driving force? Minal, would you like to tell us a couple of things about?
Yeah.
So thank you. I'm not going to switch on my camera because I've not even properly washed my face.
You're always beautiful, Minal. No worries. Yeah.
Thank you. So yes, Rajesh, it wasn't 18, 19 years. It was 12 years ago we left Orkut. But yes, 2006 onwards we were part of Orkut. And the group now has 32,000 people. We have 12,000 people on our page who could listen or who this will be broadcasted to, is broadcasted to, sorry, too much speaking there. So in the last 10 days, we have fundraised around £38,000. Would be 40 actually, because Indians in London will also donate some money from our own account. We basically have managed to get 40 concentrators, which are getting ready to be shipped to India. 20 will go to Red Cross and 20 would go to other smaller NGOs. We also have been working with other doctors like Rajesh, and Rajesh has very graciously helped a lot of our patients, giving second opinion or reassuring them. So well done to everybody. And if you do identify some genuine organizations, please tell Rajesh and we will actually like to, you know, probably put 2 concentrators to smaller towns in your region, because we're going to divide what we have to not just go to bigger cities. We want to give it to smaller cities as well. So please let Rajesh know and he will tell us where we can do our bit in your region. Thanks,
Thank
everyone.
you, Minal. Thank you very much for everything you have done, Minal. Well done.
Thank you. Thank you so much.
Okay, thank you. Thank you, sir.
Okay, we're closing now then, Vishnuji.
Yeah, thanks. Thanks a lot.
Bye-bye. Bye, everyone.
Yeah, bye-bye.
Bye-bye.
Bye-bye.